professional musician played and learned a piece that would have taken him about 12 hours. And when that piece was recorded and then exposed to professional musicologists to listen to, they said that was well done. He said, that man has practiced. That man knows his piece. The distortion of time is directly related to the manner in which we perform. And as such, the military have been carrying on a number of experiments, none of which are classified, but which are of peripheral interest in this regard. When individuals have to be confined, like astronauts, in small spaces for a long period of time, that time, when it is distorted and made to feel like a shorter time, produces less muscle tension, less fatigability than normally would occur. And the same score, now in many cases where individuals are put in casts following orthopedic surgery in the same institution I referred to this morning, many of them are taught self-hypnotic procedures to visualize themselves walking and using that part of the body which is immobilized, whether it's a leg or an arm or some part of the back, visualizing that part of the body in motion, and in motion that they like, swimming, walking, playing tennis. The results have been dramatic. Frequently following fairly serious and protracted orthopedic surgery, there is much less need for physical therapy, and the amount of physical therapy that's involved is usually vastly reduced in amount, and functioning is greatly increased, and physiatrists have become very interested in using this technique in helping rehabilitate patients. So that at the present time, again, I'm doing what Professor Markuson asked, to kind of give you a little bird's eye view of some of the things that are currently being employed and utilized. At the present time, in physical rehabilitation, hypnosis is being used quite extensively. Now, that may be true here in Italy too, but it's become a kind of major specialty among physiatrists and among the physical therapists who work with the physiatrists to utilize hypnosis in terms of rebuilding muscle function, in realigning muscle coordination. It is used extensively, for example, in the rehabilitation of patients following major orthopedic surgery, with patients with rheumatoid arthritis. Patients with multiple sclerosis have been found to improve markedly in terms of their walking capacity through the use of hypnosis. So that muscle involvement and muscle control can be enhanced, and one can transcend some of these voluntary levels. There really are no limitations in terms of the areas in which one can apply hypnosis, but there are certain ground rules that I think are related to the principles that we were dealing with earlier in the workshop and which we were focusing upon this morning. That is, the same kind of skill and the same kind of concern and the same awareness that the therapeutic relationship with hypnosis is just as important in helping somebody rehabilitate muscle function as it is in dealing with disturbing emotional problems. So that one of the areas in which hypnosis now holds great promise is dealing with the emotional reactions that patients have following serious impairment of bodily function. We have worked at the Veterans Administration some years ago with a group of veterans who had amputations, above the knee amputation. And as you know, amputation is a very threatening experience, and it's a very debilitating experience. If one wants to use some analytic terminology, the loss of a limb is equivalent to a castration experience. Even the loss of teeth sometimes has, for some patients, that implication. But certainly losing a limb, and losing a limb above the knee, which seriously incapacitates your ability, your appearance, the whole body image changes. And although most of our work was done with military amputees, in working with civilian amputees afterwards, the same reactions occur. There is depression, there is loss of ego exhilaration, there is tremendous anxiety about the way in which they appear to others, and they do not want to cooperate in their treatment or in their rehabilitation. So that, for example, at one of the VA centers in New York, they have a machine which is called a walking machine. It's computerized, and as you walk on it, it indicates your stride and your motor coordination, and there is a level at which you can gauge when you're getting normal neuromuscular motor coordination. Individuals are given prosthetic devices, legs that have electronic components, which have miniature computers built into them. They're really remarkable devices of engineering. What happens is most amputees will not use these. There was one man who was given a remarkable leg, which was attached. The first thing that happened is that when it was attached, he developed blisters at the point of attachment, so it couldn't be used. That required psychotherapy to overcome the blistering because it was not a physical problem. Then he would drag the leg around, and when he got on the walking machine, he really could not walk, despite the fact that it was a great leg. And then one day, he found and came across a temporary prosthetic device that is used before amputees are given their new prosthetic leg. And it's really like an old stump that they used to use, which simply attaches to the knee. It's a very primitive device. He put this on, and he hopped around like a child. And he said he liked this better than the other one. Because the other one, you couldn't tell that he had lost a leg. This way, he looked like he had lost a leg because it couldn't be covered over. And when he went on the walking machine with this primitive stump, he walked quite well. It requires a good deal of rehabilitative therapy to incorporate a prosthetic device into one's ego structure. It's an alienating process. It's very much like, and this is only a metaphoric equation, there is a tendency to reject prosthetics the way patients reject organs that are implanted, the way a body will reject a kidney, the way a body will reject a heart transplant. Patients reject prosthetic devices. Most dentists will tell you that they always have a number of patients who reject dentures. As one dentist said, he has several patients who always wear their dentures in their pockets. They will not put them in. They do not want a substitute for the original. And this is an ego problem, and one that is very responsive to very short-term hypnotherapy. I could go on into a variety of other areas, including the fact that in recent times, hypnosis is being used now with coma patients, and that it is possible to help facilitate a patient's recovery from coma. It doesn't occur rapidly, but it has been, in some cases, a productive device, and is not dissimilar, as I mentioned a little earlier, to the intraoperative conversation that some British investigators reported a number of years ago with anesthesia, in that if a patient is equipped with earphones under anesthesia, you can communicate with that patient during the operative procedure. Cheek has done this in California. There is no memory of that conversation, but there is response to the conversation. That conversation usually cannot even be retrieved on hypnotic levels afterwards. Occasionally some of it, but the registration is too low for retrieval. But the communication process exists, and there are a number of well-documented studies that patients under general anesthetics can hear and respond to the ideas and the instructions that are given during the surgical procedure. And as such, it coincides with the use of preoperative hypnotic intervention, and now operative intervention, and then postoperative intervention, so that one can have a totality or a kind of holistic approach in helping a patient in the transition with their anxieties, their anticipations, and their expectations preoperatively, then during the operative procedure, and postoperatively. In terms of some of the more theoretical and conceptual questions that were raised earlier, one would almost have the feeling that as time progresses, the value of hypnosis may become much greater in non-therapeutic areas than in psychotherapy, that its use as an adjunctive procedure in various areas of medicine and surgery become increasingly more valuable. Certainly, the psychological problems of cancer patients following successful cancer treatment in terms of surgery are vast, and there are a number of recent publications that indicate that some psychotherapy for patients recovering from cancer should almost be a standard part of the medical treatment of cancer. And certainly, as I discussed earlier today, the use of hypnotic procedures to manage reactions to radiation and chemotherapy are very important on a physical level. But the emotional impact and the emotional devastation of cancer to the human being places great emphasis on their need to integrate ego functions afterwards. And the fact that a patient recovers very well from cancer doesn't mean that he is or she is very well. Actually, the emotional complications from cancer are vast and go generally unrecognized. At Memorial Hospital in New York, the Sloan Kettering Foundation, almost invariably following a major cancer with major surgical intervention, the patient is told that there are now psychotherapeutic modalities available and that they would like to incorporate this into their post-surgical treatment. The patient has the right to say no, and many of them do, because they still feel that this is a limitation on their own capabilities. But many do not. And Dr. Holland, who is the director of psychiatry at Memorial, has been keeping records now for some 15 years. And some of her reports are quite interesting because she follows those who reject psychotherapy and those who accept it. And the results are strikingly different. The expectation, the life expectation of those who receive psychotherapy following comparable surgical interventions is significantly longer than those who do not get emotional help. That is in contradistinction and not to be related to the work that Bernard Siegel and others have been doing, and the Simons have been doing in terms of using hypnosis to treat cancer itself in terms of imagery. I'm not making reference to that. That's a whole different area, and it's one that I really am not prepared to deal with, although there's a great deal of it going on at the present time. But the really striking evidence in terms of contemporary findings is that a cancer patient who goes through successful medical surgical treatment of cancer can extend his or her life significantly by having psychotherapy. It doesn't have to be hypnotherapy, but they do a fair amount of hypnotherapy at Memorial. But psychotherapy, both individual and group, will extend their life almost by 4 or 5 years beyond the control group who does not get it. Now, 4 or 5 years is a considerable amount of time, and those are productive years in terms of the records that have been kept. So that I think we're seeing the utilization of therapeutic intervention in medical and surgical rehabilitative areas as becoming perhaps a more productive area for its use than even psychotherapy, for the simple reason that psychotherapy is a very difficult process at its best, regardless of the techniques or of the approaches or of the patients. But because our focus point is hypnosis and the nature of hypnosis and the nature of that relationship, I think it's important to keep these considerations in mind. Let me now just kind of review a few very simple things that will kind of tie up some of the elements that I've discussed. And then if there's a little time, there are just 1 or 2 cases that I might like to present. But let me just summarize a little bit in terms of contemporary scene. It is very clear, and I think it is really a reiteration, maybe a little more articulately, a little clearer than I've said it during these 2 days, that hypnosis cannot be viewed simply as an instrument of suggestion by itself. It is much more than an instrument of suggestion. And to reduce it to suggestibility or to an instrument of suggestion is not to demean it, and I think one doesn't have to professionally take that personally, but it is to limit its value in terms of the kinds, the range, the spectrum of patient conditions, of patient problems that can be encountered and successfully dealt with. Nor can it merely be viewed as a phenomenon of behavior that is outside of the mainstream of either psychological or physiological theory or clinical concepts in psychotherapy. I think for hypnosis to continue to be an effective therapeutic agent, it is absolutely essential to continue to link it up with advances in general psychotherapeutic strategies and tactics. I think the hypnotherapist who feels that hypnotherapy is a closed system and that it is an intact system, that it is, to use an older term, a school of psychotherapy, is missing the boat, is going to limit the use of hypnosis. Hypnosis becomes more valuable in psychotherapy and in the psychotherapies for the therapist who is able to integrate newer findings, newer concepts, newer strategies of therapeutic interaction, and then appropriately insert hypnosis in the place where it can be meaningful and effective. But not to think of hypnotherapy as a separate kind of therapy. As I said at the very beginning yesterday, I prefer to think of it as therapy at a hypnotic level, or therapy with a hypnotic tactic or strategy at times. But it is psychotherapy. If somebody were to ask me what I practice, I would not say I practice hypnotherapy, although I use hypnosis a great deal. I would say I practice psychotherapy. And I use hypnosis as a technique. It would be the same way as a physician in general practice would not say he's a penicillin injector, or that he is a tranquilizer dispenser. These are simply strategies or instruments of treatment. Hypnosis is an instrument of treatment, no more and no less. And to make it the main focus is to pull it out of the mainstream of dynamic psychology or psychiatry and of behavior science generally. And I think it has to go back in there. And I think the people who have been making the greatest advancements in hypnosis, and that certainly includes people like Professor Markuson and others, have been keeping hypnosis as part of a dynamic behavioral science. And I think increasingly part of a behavioral science that includes neuroscience. And as such, I think we don't have to view it as a narrow modality or a narrow procedure at all. And at times, one may do psychotherapy with hypnosis and use hypnosis very selectively and only at certain points in the therapy. Certainly in many hypnotherapy patients, there would be many, I have to go slower, in many patients that I would treat with some use of hypnosis, and which might be descriptively classified under hypnoanalysis or hypnotherapy, I might go many sessions in which I would never use hypnosis with them, but at strategic points, at certain elements, I would then intervene with hypnosis and use a variety of different approaches based on what has been developing, what is important, and where it can be useful. But simply to repeat the same procedure over again, because that is the framework that I operate with, I think limits it tremendously. It doesn't eliminate results, but I think it limits the broad spectrum of what one can do and achieve. And for that reason, I think it is very important that one view hypnosis as a segment of dynamic behavioral and neural science. Some of the significant trends to be noted in the present clinical utilization of hypnotherapies emphasize the distinction, and it's one that I think we're probably all aware of, but it doesn't hurt to repeat it, and I've been repeating it a little bit, and I'm sure you've, in your own minds, always repeated it. A significant distinction between the process of hypnotic induction and the hypnotic transference relationship. Every time you induce hypnosis in a patient, you are not going to get a hypnotic transference. I think this is very important. Every time an analyst sees a patient, the patient's not going to develop a transference relationship. Hypnotic transference is another aspect of the hypnotic experience. In many patients, it will not occur. That doesn't mean you can't use hypnosis, you certainly can. But when you're getting a hypnotic transference, or as McAlpin, the analyst at New York Psychoanalytic some years ago, in referring to some aspects of hypnosis in a lecture she gave at the New York Academy of Psychoanalysis, said, sometimes hypnosis produces spontaneous, instant transference. And she's right. Sometimes it does. Other times it emerges more slowly. But for the therapist who wants to make very careful and very sophisticated and very effective use of hypnosis, one must distinguish between hypnotizing a patient and the kind of therapeutic alliance that evolves after the induction. Simply to have achieved a hypnotic, quote, state does not tell you much about the relationship. And it is most important not to overlook what happens after you do an induction in the early stages, and to have some inquiry and some gentle analysis. For example, some years ago, when I was working in a psychiatric clinic, I saw a young man for a speech disorder. And along with that speech disorder, he had a number of other characterological problems, including severe repressed anger and rage and depression. And he responded very well to the hypnosis. He wasn't very revealing about what was going on, and after I saw him 4 times, after the 4th visit to the clinic, the superintendent of the building in which we maintained our psychiatric clinic came up and asked if he could talk to the person who was treating the patient who came at 4 o'clock. That's the only way he could identify him. And by looking at the schedule, they saw it was my patient. And he came into my office and he said, I don't want to interfere in what you're doing, but I think there's something you should know. Every time your patient leaves your office, he vomits in the elevator. And it has happened on 4 consecutive weeks. He thought he had some kind of stomach disorder, and that he vomits all the time. He didn't. He never vomits. The vomiting was clearly a symbolic expression of what was going on in the hypnotic relationship, and the kind of negative transference, and he couldn't stomach some of the things that he was experiencing unconsciously. And once we got into that, I was able to get him to ventilate about it, and of course, this symptomatic reaction stopped. But quite frankly, at that time, I would not have known about it if the superintendent of the building didn't tell me that the patient was vomiting in the elevator every time he left my office. It's very important, particularly with using hypnosis, and I wouldn't say it's not important in any kind of therapy, it is, but particularly with hypnosis, to find out what the patient experiences after they leave your office. For example, some years ago, I saw a man with a severe agitated depression. And during one session, he spontaneously regressed back to about 8 years of age. And he began to stutter. I didn't know that he stuttered, and in my intake history, he never indicated he had a stuttering problem. But he began to stutter, and he was going through a revivification, again, spontaneously. I had not directed it anywhere. And he described a scene in which his father was leaving the home. He was packing up and leaving for good. And he was very agitated, very upset. And he asked him not to go, and the father said, "Doesn't matter what you ask me to do, I'm going." And the father never, historically, the father never returned to the home after that. After the dehypnotization, the patient, who was a very articulate and very well-educated, certified public accountant, very intelligent man, discussed it and said, yes, he says, I stuttered about the time that my family was having trouble. And I stuttered until I was 12 years old. And then it just disappeared, as most stuttering does. As you know, the history of treating stuttering is a very difficult and frustrating area. Most people who overcome stuttering do so spontaneously. All of the efforts of speech pathologists and others notwithstanding, and their good intentions, it doesn't have as much an impact as spontaneous recovery from stuttering. But what happened here is not related to the stuttering. This man had an 8 o'clock appointment with me, standing appointment, every week. And then he would walk from my office to his accounting office, which was about a 10-minute walk in the city. He left the office as he usually does, and he'd had significant sessions before with hypnosis. About 4 o'clock that afternoon, I had a call from him. He said, "You'll never know what happened to me." I said, "Well, tell me what happened." He said, "I never got to my office this morning." He said, "For some unknown reason, I must have wandered into the subway." And he said, "I spent until 3 o'clock riding the subways back and forth until the conductor shook me and said that I had been sleeping. But he said I wasn't sleeping, I was dreaming." And he went on to describe he was dreaming all about that episode when he was 8 years old. In other words, he'd never fully dehypnotized, despite the fact that we did the usual procedure for taking somebody out of hypnosis. And he didn't walk to the office because he knew unconsciously if he went to the office, he's going to have